Our next speaker, Sergio Aquilar-Gaxiola, is really, obviously, as you see in his bio, internationally recognized for his work in mental health disorders among immigrants and Latinos, Hispanics in particular. But Sergio is well known and recognized by many of you as a longtime leader in this space, as former co-chair of our community engagement key function committee, and still current chair of our collaboration engagement domain task force. Sergio continues to be really such an important voice in helping to keep community engagement in the minds of leaders across clinical and translational research. And thank you again, Sergio. Thank you.
Buenos días. Let me say it in another way. Good morning. Well, thank you so much, Consuelo, and want to thank, in addition to you and your leadership, the planning committee. What a wonderful planning committee, and it is truly my genuine pleasure to be here, and to have an opportunity to share some of the work that we have been doing, kind of building blocks through the years. But before I do that, I want to do two things. One is 50 applications in 4 hours. Wow. 48 hours. Wow. Nonetheless, community engagement is well and alive, and it is just fantastic for those of you who came to join this wonderful meeting through that mechanism. That's what a blessing. And this is like being in a family. This has been really a family for over a decade now. And so many, familiar faces through the years that we have known each other, and looking forward to meet those that I haven't met. Really, as you said, Al, with your wonderful, powerful remarks, that we are here to engage, and you said that as well. Looking forward to that. I'm stepping in, as you see in the program, for Olbin Carrasquillo, who Consuelo said was unable to travel here today. And I have been in touch with Olbin, and he really wished to be here, but some damage happens in his property, in his house, and it was kind of scary. But more importantly, he is doing patient care. And he's doing the right thing. So what I'm gonna do, taking advantage that my youngest son have 4 kids, taught me to use the panoramic view here. So I'm gonna take a panoramic, if you allow me, and send it to, and on the other side, so I can, let's see which one is going to come out. So I can send it to Olbin, and and also I can gain a little bit of capital with my son. So I can let him know that indeed, is I have learned. So let me share with you some of the work that is being done in California, and I will focus specifically in something that we have been working for decades now, and that is the gap between those who are in need of services and those who are receiving services, or rather those who are not receiving services. And some people call it the treatment gap. And so the gap is, these are sobering, estimates that between 50 to 90% of people with serious mental disorders have not received appropriate mental health care in the past year. And actually, this is worse with some populations, as I will share with you. In the US, just to give you a sense, the levels of unmet need, those who are not receiving care, and these are who have been diagnosed with one or more mental disorders and are in need of services. Look at these numbers. Hispanics, only 3 out of 10 are receiving care. African Americans is a little bit worse. Asian Americans, even a little bit worse. But even with non-Hispanic whites, 6 out of 10 are not receiving care. And this, when you start to disaggregate the populations, there are still some lessons to learn here. I was blessed to do this study with several other colleagues, and we did it in the Central Valley in California with people of Mexican origin. And this is what we reported. Those who were in need of services and who utilized services, 1 out of 3 of the US born, people of Mexican origin, 1 out of 6 of the immigrants, and less than 1 in 10 of the migrant agricultural workers that we included in our sample, over 1,000 people that we were able to study. This was in the middle of the 90s, and things haven't changed, I can tell you. We do quite a bit of work throughout California, especially in the Central Valley, and we're doing work now in the Salinas Valley. These are the agricultural areas in California, and not much progress has been made, unfortunately. One thing that I want to emphasize is that I have, when we have in-depth interviews, people who, after being for a decade, with severe mental illness, like major depression, and who have not received services, and ask, what's happening to you? Why, in the course of 10 years, in spite of this condition, and that they have said, well, I haven't received services. And I remember a wonderful woman, but she said, not because I didn't try. I tried on several occasions, but I just wasn't able to receive services. One of the tragedies also is that when people get into the doors of service, they don't stay much. There are studies that show that up to 75% of Latinos who get into services don't return for a second time. And of course, the question is, what happened in the first time? What were the experiences that they had? And I can tell you that culture and language play a key role. But there are other things that happen. And so one of the questions is, what happens if people don't get services for, in this case, mental illness? But it is not only mental illness, because mental illness and substance abuse, mental disorders and substance abuse are intimately related to general health conditions. See, someone who suffers from diabetes have 5 times more, is more likely to also be depressed. And substance abuse is also very much involved. So, I have heard politicians actually, saying maybe people are going to outgrow, mental illness. That if you wait long enough, things are going to get better. Well, they don't. They don't. I'm here to share with you, these are some of the consequences. Like, they intensify over time. I don't know if you have it in your radar, but people with severe mental illness have a truncated life experience by 25 years. And there is some data that in the last 15 years or so, that life expectancy has been even worse. Also, this is it really gets me when I see people who haven't received treatment, to see the suffering that individuals and their families are experiencing, and also it thwarts the developmental trajectory and the potential that people have as they continue on with their lives. It actually determines as to whether people are going to marry or not, who they are going to marry, are they going to study, so many things that we take for granted are at stake when people who suffer from mental illness are not treated. And this is a big deal because I don't know if you have it in your radar also, the magnitude and the relevance of mental illness. The estimates here in the U.S. for 2 decades is that about 50% of the population is going to suffer from one or more mental illness, and that includes substance abuse as well. Which means if there are 150 here, in our lifetime, we are going to suffer from a condition. And being that we are in the profession that we have chosen, we are at even greater risk. And so this is very important to keep in mind. The other thing is that it leads to significant costs to individuals, their families, and communities. And there are things that we are unable to measure. There are economic estimates that can be done, but there are imponderables that we still don't know how to measure. So one of the questions is why? Why the treatment gap? Well, this is something that we have been studying. What are the barriers of access to care? And we can think about, at the individual level, we know the stigma is one of the major obstacles to seeking care. Also at the community level, the lack of culturally and linguistically appropriate services, as we experience that almost every day in the work that I do in California, and also the systemic level, the lack of a sufficient and appropriate health workforce. Once again, one of the big issues is the lack of engagement of people who are in need of services in behavioral health care, even in primary care. So these are tremendous challenges. If I put it in the big picture, these disparities that I already described to you, we really have to put it in the context of a growing demographic diversity. Certainly in California, this is, you cannot miss it. And this translates into a significant burden of diverse populations and diverse populations across all of these areas that you can see here, racially, ethnically, geographically, culturally, linguistically. And this translates into ill health, also premature death, and diminished productivity and social potential. And all of these are waste resources. And this constitutes truly a major U.S. public health problem. So let me give you a couple of examples of the kind of things that are being done in California, and that my hope is that it illustrates different ways in which we are approaching these disparities. One is at the state level, and this is kind of a building block, because years ago I was sharing some of this information in previous national community engagement conferences, and I'm happy to come and and bring you up to speed as to where we are in that process. There is something remarkable that is happening in California, and I wish that this is replicated in other states as well. This is kind of a Robin Hood initiative. It's called the Mental Health Services Act. And this was a proposition that California voters, passed into law, and it came into effect about 12 years ago. And it increases funding for mental health programs, especially to deal with disparities. And what it does is that it taxes roughly taxes 1% of those who make 1 million or more. I just cannot help but to tell you that, by the way, when this happened, California had like 46,000 millionaires, which, translated into good money. But one of those millionaires continues to be Tom Cruise. I just cannot forget that he made fun out of maternal depression, and I said, yes. When that happened, just to give you a sense, this past year, the tax collected, surpassed $2 billion. $2 billion. It constitutes roughly about 17% of the operating, money for the counties. So it's a good change. So one thing there are 5 different components. I'm not going to give you the details, but one of those components, in addition to community services and supports and prevention and early intervention and workforce education and training, one of them is called innovation. And these are the characteristics of the innovation. So one of the programs that I will describe to you is under prevention and early intervention, and another one is under innovation. And the program, in order to be innovative, it has to be unique and creative, has to be new, not just new to me. Promote recovery and resiliency, develop with communities, including underserved populations within communities, and lead to system transformation and new approaches. These have to be community initiated to a great extent. So one of them is called the California Reducing Disparities Project. This is, there was an investment during phase 1. There are 2 phases of millions of dollars to focus on the disparities that 5 populations have been experiencing. And as you can see on your left-hand side, those are African Americans, Asian and Pacific Islanders, Latinos, LGBTQ, and Native Americans. And from there, we develop population reports and a strategic plan that is about to be released. And then that led to what is now the second phase. And the second phase started last year. And there are 60 million that had been invested in this effort coming from the Mental Health Services Act. And there are approximately 40 projects. One of them is a statewide evaluation, but there are 5 technical assistance providers who are providing for the specific groups, population groups. Also, there are 35 what is called, we call the implementation pilot projects. And guess what? Recognizing that it's very hard for these diverse populations to get access to care. So instead of going and funding specific based evidence practices, the state decided to invest on what is called community-defined evidence. And this is promising programs and practices that are being implemented by CBOs, community-based organizations. And this money goes to identify those community-defined evidence and practices and to provide them resources for 5 years in order to raise the level of evidence. Because if that happens, then with these ongoing resources in the state, the counties are going to get some of those community-defined evidence and continue to fund them. You know, this is part of the plan that we have. So there are 2 phases, as I mentioned. There are 5 reports available, and at one point I chair with the community engagement group this report right here, because we, the center that I direct, we focus on Latinos statewide. So this second phase is funding, once again, to identify promising practices and system change recommendations to address the disparities, and this is specifically in historically underserved populations. I already told you about the priority populations and mentioned to you that there are about 40 contractors, receiving funds for 5 years or 6 years on this. So this is incredible, because the state, by the most part, they traditionally have not funded for more than 2 years or 3 years. So this is quite an investment. The second project that I want to bring to your attention is at the local level. After all, even when we speak at the national level or state level, actually things happen at the local level. So we are working with a county. This is Solano County, which is rural to some extent, and the county, came to see if we could help. This was community initiated. Actually, the communities in the county are the ones who demanded to have some progress, because after 3 years of working with some committees, not much progress was being done. And this is the first county to design a multi-phase innovation training and transformation project, and that combines 2 things: the cultural linguistically appropriate services, the class standards, with community engagement. The goals are, to improve access to and utilization mental health services, increase workforce diversity. There are 3 phases that we are working on with the county. One is to, and I will very quickly describe to you those 3 phases. And then there is an evaluation that we are doing all throughout. This is very much community initiated but evaluation driven as well. So the first phase is that we are bringing together these 3 groups of stakeholders: the community leaders themselves, the community-based organizations, and the counties. And the second phase is to bring them together and train them with a curriculum that we had been refining for over 10 years and evaluating as well. And they are going to be trained together along with representatives from various sectors, from social services, schools, churches, criminal justice, transportation, etc. And they are to be developing quality improvement projects. So what we are anticipating is that they are going to come up with specific action plans to be implemented in the 3rd phase. This is the 3rd phase. The quality improvement programs are anticipated that are going to be focused on the things that you see here, from culturally competent care as defined by themselves, and all the way to community engagement. Just to have to provide you with a little sense, we are using the quadruple aim in terms of how the county is going to streamline the services based on what you see here. The consumer experience, provider experience, health outcomes, and we have also a health economist and an epidemiologist who are working with us to come up with cost effectiveness of that as well. But, and I'm gonna finish soon. We are very much invested in healthcare, access to healthcare. And it is important, and I think that it's important that we continue to do that. But, is it the only thing that we ought to be doing? Well, no, because it's more than access to care. I want to bring to your attention what my colleague out of UC San Francisco, Schroeder, wrote in the New England Journal of Medicine that healthcare only constitutes 10% of keeping the population healthy. And look at personal behaviors, 40%, and family history and genetics, 30%, and you see the environmental and social factors as well. And so healthcare is only a part of it. And we really need to, head on, get into the business of what is unavoidable. So we need to take care, we need care that addresses the social context. And, why treat illness and send people back to live in the same conditions that made them sick in the first place? And to pretend that just because they come for services, we see them for 15 minutes and at the most an hour, and that they are going to be back and everything is going to change. I love this quote by Tom Frieden. Addressing socioeconomic factors has the greatest potential to improve health. Achieving social and economic change might require fundamental societal transformation. Interventions that address social determinants of health have the greatest potential for public health benefit. Absolutely, absolutely. It is unavoidable. And this is important to coming to terms with health inequities, excuse me. Unhealthy housing, environmental hazards, limited access to food, and exercise, unsafe neighborhoods, and all the other factors that you see here, including impact of chronic stress, play a key role on keeping the populations healthy, not only to make sure that they have access to care. So I would like to leave you with these 5 questions that a great colleague of mine, David Williams, shared with me. We co-presented in Madison last year, and these are questions about new directions that we ought to be thinking, in my opinion. How can we identify patients' non-medical health needs as part of their overall care? How can we connect patients to local services, resources that help people avoid getting sick in the first place, or better manage illness, including mental health needs? How can we be a strong leader and champion to collaborate with other sectors to improve health where patients live, learn, work, and play? How can we connect community residents to jobs in the healthcare sector, one of the largest employers? Actually, there is evidence that the health sector is going to be, in some states, the most important employer in the next several years. So this is a good question. It's a fair question. And finally, how can we use community health workers to provide services or link patients to needed supports? So I'm concluding the remarks here. I don't know if there are going to be questions at times for questions. Thank you so much again.